Welcome to segment 8 of the Falcon Physician Review's Anatomy Online. This next segment, with regions of the spine and curves of the spine, will move quite quickly because it's really just highlighting some of the things that you've probably already mastered, but we must make sure of because there'll be some key important portions that will carry through to the other portions of these reviews. It's also critical that you know that 40% of primary care visits are musculoskeletal in nature. So we have our basic regions of the vertebrae, which I'm sure you're familiar with. Add to that data, if you're not already aware, that there are 24 movable vertebrae that are presacral, and a couple components, the sacrum and coccyx, which are postsacral and, of course, fused. That gives a total of 33 vertebral segments, which make up the primary and secondary curvatures of the vertebral column. Notice in the infant on the side that the primary curvatures are not as obvious as they are in the adult spine to the left of that. So what are the curvatures? Well, the secondary curvatures are the curvatures that develop after the primaries. The cervical one is present at birth. It's just the musculature that needs to develop control of those large Charlie Brown heads that babies have so that they can look around their environment. The second curvature, which is in the lumbar region, is going to take a year to develop through the differential growth of the lumbar vertebrae. So most of the growth that occurs in the vertebral column with its expansion occurs at the lumbar region, and the anterior components of those lumbar vertebrae and the discs grow faster than the posterior versions, therefore it gives a secondary curvature. The primary curvatures, however, exist in the thoracic and the sacral regions, and they are there at birth. So you can see that the primary curvature is concave, the secondary curvature is convex. The important thing to remember about the curvatures is that osteophyte formations tend to form at the concavities of each curvature. Therefore, in the secondary curvatures, osteophyte formations tend to be posterior, and in the primary curvatures, osteophyte formations tend to be anterior. Because of the positioning of the intervertebral nerve, it's the posterior ones that are more compressive in nature, and the anterior osteophytes tend to give you less clinical problems. So when we look at curvatures that have clinical significance, there are lateral curvatures such as a scoliosis. The thing that you want to remember about a scoliosis is that it's a lateral deviation, but it's always accompanied by a rotation. And any rotation of the spine causes to bring the vertebrae closer together and puts the disc under compressive forces, leading to an increased chance of herniation. So as a red flag, if you have someone that has a slight curvature of the spine or an exaggerated curvature of the spine, these lead to increased possibility of disc herniation and nerve compression. On an AP plain film, the spine of an individual with a typical scoliosis may look more like an S or a C than the straight line. And it's classified as congenital, idiopathic, and also neuromuscular. The congenital ones, of course, you're born with. The idiopathic can be either juvenile, infantile, adolescent, or adult in formation. And the neuromuscular ones tend to be as a secondary sign of another condition. For instance, spina bifida, cerebral palsy, spinal muscular atrophy, or physical trauma or paralysis, which allows one side to be loose and the other side to have tone with the unopposed action of those other muscles. They are more common in females than males. However, this does not mean that males don't get curvatures. When we look at the regional susceptibility, we know already that the facets that are present at the cervical, thoracic, and lumbar regions are in different planes, which give you different mobilities, and therefore keep your eyes and ears tuned to those different mobilities so that in question stems you'll actually have a red flag that will tell you which region is likely to be affected. As an example, the cervical vertebrae have great rotational abilities, but they have to rely heavily on the occiput and C1 for the yes motions, and heavily on C1 and C2 joints for the movements of no. 50% of the yes and no functions come from those respective joints alone. The rest of those functions are summated through the rest of the cervical vertebrae. But one of the things that the range of motion and the direction of motion will help to dictate is the susceptibility to injuries. For instance, in those cervical regions, especially between the dens and the axis and atlas, there's going to be different types of odontoid fractures that can happen there. And type 1 are more stable, but type 2 and 3 will require a halo because they are neurologically unstable. If you look at the C2 vertebrae, it also has a susceptibility to fracturing through the lamina, which would be the hangman's fracture, which should probably be called the hanged man's fracture since they're the one that always dies. And that's basically a traumatic spondylolisthesis. So anytime you see spondylolisthesis, it's a bilateral fracture through the lamina. If it's one-sided, it's known as a spondylosis. Now, the other thing up at the cervical region, because it's so good at rotation, it's susceptible to forward displacements and dislocations. So suspect cervical damage in dislocations that will go forward, such as it would occur in a whiplash injury. If you're into the thoracic region, this area is great for rotation, not so great for flexion, although it will summate through the 12 vertebrae quite nicely, and not so great for extension. So a lot of the problems that you see with the facets in the thoracic region will be rotational problems, and oftentimes you'll have more avulsion fractures and dislocations at this point. In the lumbar, because now it's starting to become a higher weight-bearing area, and they're very good at forward flexion and extension, but terrible at rotation or side flexion, you oftentimes will get weight-associated fractures with these. For instance, the person that jumps out of a building or falls off of a balcony, lands on their feet, and they can get burst fractures, or these can even have retropulsions to them, which will spew contents back into the vertebral canal and cause spinal cord compression issues. One of these such injuries in the lumbar region tends to be osteoporosis associated. These vertebral body compression fractures associated with the compression are very common, more common by 2 times than the hip fractures that you often hear about. So don't be surprised if you see something with a vertebral compression fracture in a patient that has osteoporosis as part of the stem. In fact, 40% of women 80 years or older will have some form of osteoporotic vertebral compression fracture. But many of these go undiagnosed, and the mortality rate is similar to that of hip fractures, but because of the loss of diagnosis, only 1/3 of them are actually given assistance. Something more common that you should be very familiar with is sciatica. Remember, sciatica is a radiculopathy that gives you radiating pain that must travel below the knee. That's your red flag. If it doesn't travel below the knee, it's not a true sciatica. There's a series of symptoms and signs that will not give you a diagnosis, but will kind of point you in the right direction. What are the causes? Well, they can be compression in the spinal canal. There can be nerve root compressions because of herniated discs or stenosis, and oftentimes pregnancy. But remember, nerve root compressions often will need multiple levels to give you a true sciatica, which is why you may not see that nerve root compression shooting past the knee. And oftentimes it would be an entrapment of some sort, either through scar tissue or what you'll sometimes see is an entrapment in piriformis muscle, because about 17% of people have their divisions of the sciatic nerve dividing through the piriformis, so that if that muscle spasms because of its lateral rotator work, you can have sciatica being produced. Let's look at what this means if there's a vertebral compression as a result of a herniation. Remember that herniations will oftentimes occur at the weak points of the annulus fibrosus, and the nucleus pulposus will be pushed out of that weak point. This shows an MRI of a herniated disc. What I want you to be aware of here is that just because you see an MRI with a herniated disc does not mean that people have symptoms of spinal or nerve compression. You only want to worry about the ones that actually are symptomatic, because many of these, maybe as many as 60% of disc herniations, are actually asymptomatic. Here you can see someone going through a leg stretch test, or often called a leg lift test for sciatic nerve compression. What you want to remember about this is you need to differentiate between tight hamstrings or torn muscles and a sciatic nerve stretch. So what you do is you elevate the person's leg, as shown in the picture, all the way up until they say, okay, that starts to hurt. Then you back off slightly, just to the point where it's right before the pain point, and then start to dorsiflex the foot passively. This will stretch the sciatic nerve, and if it is a sciatic nerve issue indeed, you will have the reproduction of the pain sign. If it's a hamstring issue, since the dorsiflexion should not increase the stretch of the hamstring muscles at all, you can then differentiate between those two. Okay. We've talked about some of the embryonic things, and we've talked about some of the rotational things. As a summary, let's just pull together a few things that we've learned about vertebral defects. First of all, there's symmetry to these things. Oftentimes the scoliosis will change the symmetry so that there'll be a lateral curvature. Sometimes that's because of the development of an extra vertebrae. With understanding how the vertebrae form, it's easy now to comprehend why you can sometimes have one half of a vertebrae form through the mechanisms that we've discussed earlier. The kyphosis, which is going to be an increased primary curvature, and a lordosis, which could be an increased secondary curvature. There are natural amounts of kyphosis and lordosis in each of these curves, but when they become hyperkyphotic or hyperlordotic, this is when you'll oftentimes see pathology. We talked about all of the closure issues with dysraphism. This includes the rachesthesis, the spine division, and this usually involves the CNS. We've talked about the spina bifida, which translates to mean split spine, with the occulta giving us the hair and the arch problems, but the overall general repairability of that. Then they start getting worse as the names get longer. The meningocele, which is an expansion of the CSF space in the theca. Then we have the myelomeningocele, which would be the inclusion of the cord outside of the vertebral canal, but it would still be covered by a dura mater. And then the schisis, the myeloschisis, which is the worst of these, and that would have an exposed cord and always deals with the paralysis of the infant. Now, another important part clinically of the vertebral column is actually its venous drainage, which is kind of different from a lot of important clinical things where we tend to think about the vascular arterial supply. But in this case, the venous drainage of the vertebral column is important because there's two types of plexes, all of which interconnect without an interposed venous valve. So the anterior and posterior portions of both the internal and external venous plexus connect without valves. The internal venous plexus is within the vertebral canal, and the external vertebral venous plexus is outside of the vertebral canal. The internal plexus is going to be epidural, and the anterior of both of these, with the internal plexus, the anterior is more extensive, and the external plexus, the posterior, is more extensive. So the body has less drainage than the neural arch. Here you can see one of these important veins that's draining the body, known as the basivertebral vein. This can sometimes be compressed when there's a compression fracture, and that can cause a necrosis. The clinically important factor about this venous plexus is that it's valveless and therefore a viable pathway for metastasis of cancer. So you'll oftentimes get pelvic cancers that will then metastasize into the vertebral canal and can make their way up through into the spinal cord or into the brain. Something that people classically have difficulty with, we're going to spend a little bit of time on, which would be the intervertebral discs and the herniations. Herniations typically occur, if you think of the disc as a clock face, at the 5 and 7 o'clock positions. And the 5 and 7 o'clock positions have a weaker annulus fibrosus at that point. It's thicker at the 6 o'clock position because of the posterior longitudinal ligament that's running along there. The anterior is also reinforced because of the anterior longitudinal ligaments. So it ends up being that this 5 and 7 o'clock position are naturally the egress points for any extrusion of the nucleus pulposus. If this happens and it blocks an intervertebral foramen, it's going to have nerve compression and give you radiculopathy signs. If it occurs posteriorly, though, it can push either on the spinal cord itself, or if it's lower down, will push on the cauda equina, give you something known as a cauda equina syndrome. Let's think of a question first. A 57-year-old male is seen for radiating pain in the low back. A CT exam reveals a posterior lateral herniation of the L4, L5 intervertebral disc. Which nerve will most likely be affected by this injury? The instinct at this point is to know that the nerves of each vertebral level in the thoracic and lumbar region exit below the vertebrae that they're numbered after, whereas in the cervical region those nerves exit above the vertebrae at which they're numbered. In this case, people are instinctively wanting to pick L4 as their answer, but there's an anatomic reason that this answer is actually L5. Let's discuss that. Here you can see the vertebral column with the 8 cervical nerves, 12 thoracic, and 5 lumbar. Remember their distribution so that the cervical nerves come out above and the thoracic and lumbar nerves come out below the vertebrae from which they're numbered, simply because 8 cervical nerves associated with 7 cervical vertebrae require that C1 come out above the C1 vertebrae. So if we look at the C4-5 disc, we look at the T4-5 disc, and we look at the L4-5 disc, and think about a herniated disc at each of those levels, what do we want to take away from this when we're dealing with questions for the step 1? If you look at the C4-5 herniation, remember the nerves are coming out right at the level of the disc, so any kind of herniation at that point will indeed compress the C5 nerve if it's between C4-5 because of the nerve traveling above the vertebrae. So therefore we have a C5 herniation. If we do the same thing at the T4, T5, because it's coming out right at the disc level again, but this time the nerves are numbered below the vertebrae from which they come out, now we'll see a T4 herniation. When you get to the lumbar regions, the L4, L5 herniation, you can see how high up the intervertebral notch is on the L4 vertebrae. That's because of the body being so much larger in the lumbar region than they are in the cervical and thoracic region. Therefore, there's enough space for the L4 nerve to exit from the intervertebral foramina prior to the disc. So the disc retropulsing at the 5 and 7 o'clock location will actually not compress the L4 because it's already exited above the level of the disc. That means that it's the next nerve down that's trying to angulate out and get through the next intervertebral foramina that's going to get the nerve root compressed by the disc. And here you can see the L4, L5 disc. You can see how the arch will be too high to compress L4, but the next one getting compressed will be that L5 nerve as it tries to exit. So this is one way you can logic through that, or you can simply memorize the fact that if the nerve exits at the cervical level, it's going to be the bottom of the two. If it exits or retropulses in the thoracic level, it will be the top one of the two. And if it's in the lumbar level, it will be the bottom of the two again. Hopefully this will help you deal with these questions as they come into discussing the intervertebral foramina and the disc herniation. One last thing I want to put on your minds as far as the rotation and the movements. Remember, it's the facets that dictate the direction of movement. It's the intervertebral disc that dictate the amount of movement. Since the discs are bigger in the lumbar region, there's more movement at those levels than there are higher up at the cervical region where the discs are smaller. That concludes Section 8 on the regions and curves of the spine. The next component that we'll look at will be 9, the basic nervous system and referred pain.